Dr. Elaine Abebu, and she's an obstetrician gynecologist at the Kolebu Teaching Hospital. Dr. Abebu, you're welcome.
Thank you very much.
Thank you for joining us. And then joining us virtually, we have two other guests. We have Dr. Gloria Amponsakodia. She's no guest to us on the consulting room, and she's a pediatrician and also the executive director of Healthy Kids Foundation. Dr. Amponsakodia, you're welcome again to the consulting room. And then also...
Thank you very much, Nan.
Yeah.
Thank you.
We have one more guest, Josephine Osei Tonto. She's a NICU nurse at the Kumasi South Hospital. I'm sure we'll know more what a NICU is as we go into this discussion. Thank you all so much for joining us tonight. I'm sure you're all very eager to get into this discussion, but we'll go for a quick commercial break, and when we get back, we'll start this conversation. Please stay tuned.
Wala shin le fio na agba beikomen le iwa ke ona hino kamo ye agba ile amen shin ye wodum be amen tetekole kan e fio gio enye gbo eho ine won 7th day Adventist astafo mission driven purpose the hope channel ke shin le ye hino kamo mlen sane pepa shiamo no chimo ba ogbeno ne ni osofo titri ni ba ye ni femo la shinji osofo kojo chumesi woni ba chon gbomo chon wale pepa na mon le he ni biji datrefonyo ile di donko Money bachon blanching like a wicked cramo, I mean like so something chubby. Money by way while I walk and dollar his allergy, that refunyo coffee chumesi, and she lay a hino come on and sanic papa share money. I know yesterday Adventist as a for family. Ke Hope Channel TV at a feature at Majin Lefin Anno. Monich money, Abano dad, Beck and Maji Ekba, Keja Afuabi, Clink Bileno, Kiashino Nijin, ye Afia Peño, my enyoke etenemly. Shin le ye no kamomne ejigbi ne hu kan chakemo kan ha eneho ohe ite kokoko no nchole ajobu baba o.
A perfect marriage is just two imperfect people who refuse to give up on each other. As we end the year, it is a great opportunity to rekindle the joy in your marriage. The One Garrison SDA Church invites you to the end of year couples dinner dubbed The Joy in Your Marriage. Date 2nd December 2023. Venue One Garrison SDA Church, Michelle Camp. Time 4 p.m. to 8 p.m. Guest speakers Pastor Kenel P. N.K. Dodu and Pastor Emmanuel Dixon. Come and deepen the joy in your marriage with some great secrets. See you there.
Welcome back from the commercial break. Our topic of discussion for today is small actions, big impact, prematurity awareness. So I'll just start from Dr. Abebu. You're welcome again.
Thank you very much.
Okay. So who do we consider as a premature baby or a preemie?
All right. So, as you said earlier, I am an obstetrician gynecologist, so I'll speak from my obs and gyne point of view. In Ghana, we consider babies who are born before what we call 37 completed weeks, as preterm. And I'm sure the pediatricians will go into details because we have the very preterm, the late preterm. Yes, but for Ghana, we consider any baby born before 37 completed weeks as preterm.
Okay.
Yes.
But what features will you note on that kind of baby?
Okay, so that kind of baby is generally smaller when they are delivered. They tend to be less, chubby as per our normal babies. They are a bit thinner, and their skin is, should I say, gel-like or gelatinous. Sometimes you'll be able to even see the veins underneath their skin. Their movements are a bit slower, so they wouldn't be sucking as aggressively as the normal babies. Their cries are a bit weaker, sometimes even a bit shrill. Yes, and then their external genitalia, so the private parts are not as developed as you would see in a baby that was born at the normal time, a full-term baby. And then when you look under the soles of their feet and then in their palms, it also doesn't, it's a bit smoother than you would see in a normal or a term baby. Yes. A full-grown baby.
Dr. Mponsa-Kodia, I think we'll take your view from the pediatrician side.
As almost said it all. Yes, so the genitalia or the private parts for the male preterms, you'd notice that you're supposed to see a lot of folds. So on the scrotum, it's supposed to appear dark, and then you see creases or folds on them for a baby that is born 10 or at 9 months. Usually for a baby who is preterm, it's smoother than the other babies. And then you may not be able to feel the testes, the balls in the scrotum, in the sac. And that should also tell you that this baby may be preterm. And they are, like she said, they are smaller. The movements are also a little bit slower. And then they look pinker, so like more fair than the other babies. Basically, that is what would let a lay person know that this baby is preterm. And they have these small hairs, so we call them lanugo hairs. They are thin, they are small, they are fine, and you see them on the back, on the arms, sometimes on the forehead, the face, the forehead, and that should also let you know that this baby is preterm. And when you have a normal or a full-term baby, a baby born at 9 months, their arms are a bit flexed, so they are folded like this. Their legs are also a bit folded, but a preterm is a bit floppy, so their legs may be stretched, their arms may also be stretched instead of being flexed, so like bent at the elbow like that, and the activity generally is slower. In the hospital, they have a scoring system, more complex way of telling the ages. But for a layman, these things would let you know that the baby may be preterm.
Okay. So Dr. Mponsa-Kodia, why is it so important to have a whole month set aside to create awareness on prematurity?
Yes, we need to do that. Prematurity is very important to the pediatrician, the pediatric nurse, anybody who works with babies, because a lot of them, if they are not well cared for, die. And it's a condition that has some risk factors, which we'll talk about later, which if we are able to control, we can prevent. And then there are also a lot of myths surrounding these babies, which need to be addressed. So we need to increase the awareness. And there are also success stories. So even though some of them, if not well cared for, may lose their lives, there are also things that we do for them that increase their chances of survival. And there are some children, in fact, a lot of preterms who have survived, and their stories have to be told so that people are also encouraged that, yes, even if they have a preterm baby, their babies can make it. So it's very important that we have a whole month set aside to create awareness on prematurity.
Okay, thank you so much. Dr. Baby, I'll come back to you. What are the likely causes of prematurity or preterm birth?
All right. Thank you for that. So we look at it from the point of the pregnant woman. And I must say that preterm birth is not necessarily a vaginal birth.
Okay.
It may also be a cesarean section.
Okay.
So in that case, it would have had to be an emergency cesarean section. Okay. And you can look at it from the maternal causes and then the fetal causes.
Okay.
Or you look at the liquor around the baby. So it could have been from the intrauterine or in the womb.
Okay.
Certain conditions in the in the womb that were not favorable for the baby. So was it that there wasn't enough fluid around the baby? The fluid around the baby is what we call liquor. Was it that there wasn't enough fluid around the baby? And that's actually the commonest cause of prematurity, preterm labor, or preterm, what we call preterm pre-labor rupture of membranes, where there's what we call, when we say a woman is losing liquor before she goes into labor.
Okay.
Yes. Or her water has broken, in layman's terms. Yes. And then we also have the placental causes.
Okay.
So for the placental causes, when there's a premature detachment of the placenta from the uterine wall, which we call placenta abruptio, in that case, there's a rush to save the baby's life. So if the baby is alive and there's no longer that connection from the mother to the baby, we have to quickly deliver the baby.
Okay.
And then when there's a placenta previa, so the placenta is also low, it's sometimes covering the cervix, the opening of the womb. And then it's as the womb is, as the cervix is sometimes dilating, it tends to cause a lot of bleeding, which can actually cause the mother to die. So in that case, we also have to quickly deliver the baby. So I talked earlier about the fluid around the baby. It can either be too small when the waters break early, or it can be too much, what we call polyhydramnios. In that case too, it causes it's like when you have a balloon that is so big, you've blown too much water, air in it, it can burst.
Okay.
So in that case too, they're also prone to being born early. And then when we come to the fetus itself, so when you have more than one baby in the womb, so you have a multifetal gestation, whether it's a triplets or twins or quadruplets, they also tend to be born earlier.
Okay.
Or maybe the woman just came for antenatal, the midwife checked her heart, the heart of the baby, realized that this baby's heart is not beating well. We have to deliver earlier. Or as we are following the growth of the baby, anytime the woman comes for antenatal, we are realizing that the measurement of her abdomen is not really matching how far along the pregnancy has gone, what we call intrauterine growth restriction.
Okay.
In that case, we may also have to deliver the baby earlier because the baby is at risk of dying. Then the mother, maternal conditions. So certain medical conditions, most especially hypertension. I'm sure most of us have heard of preeclampsia, eclampsia. In that case, it's a battle for the mother's life because we have to deliver that baby, take out the placenta because that is the cause of the BP's rising. And then we also have mothers who are sickle cell patients. We also don't want to lose them, so sometimes we may have to deliver the baby earlier because the crisis worsen in pregnancy. Generally, women who have had a previous preterm birth are also prone to having another birth. Infections like chlamydia also can cause preterm birth. If the woman also has an infection of her kidney or her urine, what we call pyelonephritis, that one too can lead to preterm labor. And then women who are extremes of age, so women who are below the ages of 20 or greater than the ages of 35, they are also prone to preterm births. And the list goes on and on and on.
Okay.
So basically, that's how we classify these kind of risk factors.
Okay. Okay. But what happens to a mother who goes into premature labor?
Okay. So she's immediately admitted. It could be that she's just having what we call preterm contractions,
Okay.
which is just pain on the womb, but not necessarily resulting in the opening of the entrance to her womb, which is her cervix. In that case, we just give them some drugs. We have what we call them. I won't go into details, but we just give them some drugs in order to abort the contractions.
Okay.
But in the case where these painful contractions are associated with opening of the cervix, it's sometimes a bit difficult to, delay the birth. Yes, sometimes the baby is almost about coming out, and one of the causes is a cervical insufficiency.
Okay.
So in this case, her cervix is weak. In that case, if the baby is already on the way out, all we can do is that we give what we call steroids.
Okay.
The steroids aid with the maturity of the lungs. So in that case, when the baby is born early, the chances of the baby's survival are higher. Okay. And then we also, if it's due to an infection, because infection, as I mentioned, is one of the causes, we also put them on antibiotics.
Okay.
And that has also been shown to prolong the chances of keeping the baby in that intrauterine environment a bit longer. Okay. So those are the things that we do for the woman. If she's dehydrated, we try and give her some IV fluids as well. And then if the facility where all this has been diagnosed doesn't have NICU services, then we try and give these, what I mentioned earlier, the tocolytics, in order to reduce the contraction so that we can quickly transfer her to a bigger facility with NICU services where she can be taken care of. So basically, those are the things we do for a woman in preterm labor.
Okay, all right, thank you. Josephine, I'll come to you now. So Dr. Baby has mentioned NICU. If you could educate us a bit, what is a NICU? What is a NICU? And what should we expect at a NICU?
Okay, if I heard, I can barely hear what you are saying, but if I heard you rightly, I heard you asked what a NICU is.
Yeah.
Sorry?
Yes. What is a
Okay,
NICU?
so a NICU is a neonatal intensive. Okay, it's a neonatal intensive care unit. So it's a place where neonates who are critically ill are kept and nursed.
Okay, so what do we expect to have at a NICU?
So basically, the NICU should be a warm place because it's a place to keep newborn babies. It's usually warm, not so lit, because these new babies are kind of in the transition. So we don't want to expose them to everything excessive. So we would want to nurse them in dim light, in a very, very warm environment, and then a very quiet environment.
Okay, all right. Thank you so much. Dr. Baby, I'll come back to you. So in the case where the labor couldn't be stopped and the preterm baby is coming through the birth canal, what are some of the problems or complications they might face?
Okay, so these babies are they haven't yet developed the sense of swallowing very well. I mean, it's there, but it's not as good as it should be. So they can tend to, what we call aspirate. So certain secretions can go into the wrong canal. It can go into their nostrils. It can enter into their lungs, and they are more prone to what we call fetal distress. So their heart rates will go up very high, and that's why we sometimes have to rush to perform a cesarean session for these cases, because they end up developing fetal distress. And also, they don't, as babies are growing, the chances of they presenting cephalic, so the babies usually turn, and then their heads will now come down, and then their legs will be up. But in preterm labor, sometimes their legs are still down because they haven't yet turned, and then allowing for a cephalic presentation. So some of them come with what we call malpresentations. And in that case, it means that they are going to be born breech. And breech delivery, or when you are delivering a baby with the buttocks or the legs, it's more dangerous than a normal delivery where the baby is coming with the head. So in such a case, they are also prone to birth injuries, so fractures, sometimes dislocations, and other complications. And also they may have to be delivered with certain instruments, so like the forceps, It's an instrument we sometimes have to use to deliver the head if it's coming with the legs.
Okay.
And we are actually more prone to perform a cesarean section on the mother instead of allowing her to have a normal vaginal delivery, which, and you know, cesarean section also comes with its complications. So those are the possible, you know, risk factors associated with the preterm birth.
Okay.
And hence we need the pediatricians usually to be at the delivery to help us with resuscitation in this case.
Okay, yes. So that's actually my next question to Dr. Amponsa Kodia. How are premature babies managed after birth in the hospital?
We'll not go into that. Preterm babies or premature babies sometimes tend to become cold, so we call it hypothermia. They don't have a lot of fat because they didn't really develop to full 10 to the 9 months. The last 3 months, they put on a lot of weight, they accumulate a lot of fat. So if they come before the 9 months, they may not have gotten a lot of fat. And this fat sort of prevents heat from getting lost from their body. So when the fat is very small or is low, then they are prone to losing heat. So they become cold. And if they are cold and they are not managed well, they can die from the cold. So we try to prevent them from getting cold by putting them in an incubator or under a light that also, or something that produces heat. We call it radiant heater or radiant warmer to just keep them warm. So managing their temperature is very important. The other thing too that we look at is their ability to breathe. Sometimes because the lungs are not developed very well, or certain chemicals that are supposed to keep the lungs open when they breathe out may not be in sufficient quantities. When they breathe out, they struggle to breathe in again. So they have a lot of difficulty breathing in and out. And we sometimes have to support their breathing by giving them oxygen or by putting them on certain machines that will help them to breathe better. And sometimes they also stop breathing. The part of the brain that controls the breathing may also not have been developed very well. So they breathe and then at a point they stop breathing. So it's called apnea. The heart is still beating, they are still alive, but if that is also not addressed, they can die within minutes. So we also give them medication to stimulate that part of the brain that controls their breathing in and out. So that is also addressed in preterm babies. And then also there is a feeding difficulty. Um, when they are not fully mature, sometimes the ability to latch even on to the breast and then suck and even swallow or coordinate their breathing and then their swallowing can be difficult. You even have to pass a tube through their mouth or through their nose into their stomach and then feed the breast milk through the tube. Sometimes they're able to swallow, but they just cannot suckle. And so the mothers are taught to express the breast milk and then feed through cups or through spoon. And they are also at risk of infection. So we are careful, handling them. Then where they are at very preterm or they are at that risks for infection, we give them antibiotics also. And preterm babies are also prone to getting jaundice. And so we monitor for that, and then if we see it, we also address that. So basically, these are the major problems that with, and this is how we treat them. And we also give them IV fluids when the breast milk is not enough, because we don't want them to lose water. If you don't replace it either with breast milk or the fluids that is given into the vein or through the vein, then they are going to become dehydrated, or the amount of water in their body is going to go very low, and that is also not good. So NICU, when they are born.
Okay, Dr. Mpansaku, they're still with you. You mentioned that they are at very high risk of infections, but we also know that skin-to-skin contact is very important for them. So where do we draw the line?
Yes, yes. Actually, skin to skin contact has been found to be very, very important to um, these preterm babies. In fact, it helps with their breathing, helps them to breathe better. It's been found to help them to even feed better because they are close to the breast. And so their feeding is better. It helps their hearts to beat better. It helps with the temperature control. And so it's very important. It also even helps with infection prevention,
Okay.
contrary to what we may think. As you put the baby to the skin or to the chest of the mother, so that is basically what skin to skin is. And the baby is put just in the diaper, and maybe if Josephine comes on, she may be able to demonstrate or even show how it's done. So baby in diaper, no clothes, is put in between the mother's breast or on the chest of the mother, and mother's bare chest. So there is that contact skin between the skin of the mother and the skin of the baby. And then they are both wrapped with a cloth. So that is what skin to skin basically is. And yes, so we are concerned about infection, but actually the studies supports the fact that skin to skin contact even prevents infection in these babies. You see, as they are close to the mother, the handling goes down, from staff handling by staff handling by even the mother herself, because she's there. If she needs the breast, can easily access it, goes down. And that also reduces the risk of infection. And even on the mother's skin, so there are organisms or germs on the mother's skin, but some of these germs are actually not harmful.
Okay.
And we are saying that even skin, they sort of swallow these germs, and some of them are actually protective. What we call they go into the take the infant or actually prevents them also from getting infection. So yes, I mean, people may be skeptical when it all started. The mother's skin, it's dirty, there are lots of germs on it and all that, but the studies actually point to the fact that it rather reduces the risk of infection. So it's beneficial, it's helpful.
Okay. Okay. So Josephine, how soon should the preterm baby have the skin-to-skin contact?
Well, there isn't any specific time, but all things being equal, if the baby is well and the mother is well, baby can start KMC right after birth. In fact, even the process of the birthing process has skin to skin in the process because the baby is put to the mother's abdomen right after delivery, even before the cord is clamped and then cut. So if mother is fine, baby is also fine, KMC can start right away.
Oh, Josephine, you said KMC. We don't know what KMC is.
Oh, sorry, that is it's kangaroo mother care. So it's just like a skin to skin.
Okay. Okay. So how is that done?
Okay, so okay, I would like to demonstrate it to you. But
Okay. Sure.
before skin to skin is done, we would first of all would want to check the baby's temperature to know the baseline of the baby's temperature,
Okay.
and then you would put baby into diapers, take off baby's clothes, and then put baby into mittens, something like a socks on the baby's fingers,
Okay.
and then socks on their feet, and then a cap on their head.
Okay.
And so you will put baby in between your breast or on the chest of the mother like this, with all the things I've mentioned. And then you will put a cloth behind the babies like this. And then you will use a bigger cloth. You first of all have to send the baby's head to the side so that you wouldn't have to touch the mother's chest and impede their breathing. Then you use a bigger cloth to wrap the baby, making sure that you are not making it too tight to make it hurt the baby or the mother. At home, someone could help you tie the knots at your back. If you are alone too, you can do it by yourself by tying it on the side. There are various ways of doing it. So I would want to do it on the side because I'm here by myself.
Unfortunately, I can't see the demonstration. I hope our viewers can
So
see
you tie it this way.
Yeah.
And then down to you can tie it the same way. So you can go about your regular chores with baby in front of you like that. In fact, they can be there for as long as you wish. And for as long as you want baby, you can handle it. Baby could be there for like 2 hours minimum, and then you do it in series maybe 4 times within the day.
Okay, okay. So you keep mentioning mother. Is it just the mother who can do that?
Sorry?
You keep mentioning the mother. Is it just the mother who can do the KMC?
No, any relative, the father or anybody who is there to help with the baby's care would assist with the skin to skin care.
Okay, all right. Thank you so much for that. Dr. Amponsa Kodia, please, is there any support available to parents of premature babies?
Yes, some centers actually have parent support groups.
Okay.
So these mothers who have had babies who are premature, who survived, come together and then, encourage themselves. And then for the new mothers who have had preterm babies, they also encourage them that they can actually have babies growing up well. Unfortunately, in terms of finances, I don't know of any institution that supports them. Sometimes you get benevolent people, philanthropists just coming around to give donations to mothers at the NICU, and then for people who need drugs. But basically, it's the support groups that help them. They come together, they form a support group, and then they encourage each other.
Okay. Are there any precautions?
Can I add something to that?
Oh, yeah, sure.
Okay, so I think there is a lot of support, and unfortunately, most of our NICUs don't have their mothers living inside the facility with their babies. But there are others who are lucky to have MBUs where the mothers live there with the babies. So they are basically part of the care of their babies. And I think that is very supportive because right from day one, they have access to their babies and they are part of the care. So they know what is happening to their babies every day, every minute. They know what is happening to their babies. Unlike elsewhere where people would have to go home and then come back, going home and then thinking of what might be happening to their babies in the NICUs. So I think that it's very healthy when we have the mothers and the babies living in the same environment. That way they are informed of their baby's care every time and they know what goes on in the NICU. And I think that alone is a lot of support.
Okay, right. Josephine, I think our viewers didn't see your demonstrations. If you don't mind repeating it for us.
Sorry?
Our viewers didn't see your demonstration, how to do the skin to skin. So if you can repeat it for us.
How I tie the baby?
Yes.
Okay. So there are various ways of going about it.
Okay.
Some would use even the inner vest that we use inside the dresses and then put the babies in.
Okay.
But this is what we do at our factory. You put the baby in mittens, in socks, take off baby's clothing, put baby in diapers, and
Okay.
then put a hat on the baby's head.
Okay.
And then you put baby on your bare chest, you put the baby on your chest like this, just like the way you would carry baby at the back.
Okay.
And then you put a cloth behind the baby like this,
Okay.
as an insulator.
Mm.
And then with a bigger cloth, you would wrap the baby. If you have someone at home to help you, they could tie it at your back
Okay.
for you. But because I am here all by myself, I would want to tie it on the side.
Okay.
Making sure that baby is not hurting, and then the head is turned to the left. My dummy's head cannot be turned to the left. That is why it's facing me.
Okay. Justin, I think you're done with the demonstration, right?
Yes, I'm done.
Okay, right. Thank you so much. But let me just ask you, are there any precautions that mothers or carers of premature babies should take when handling them? Any precautions that handlers of premature babies should take, the carers or mothers? What precautions should they take when handling these babies?
Yes, because is that for Dr. Kodia?
No, for you, you can go first.
Okay.
Yeah.
All right. So because these babies are immunocompromised, I mean, these babies just came to the world unarmed. They didn't come prepared. They were sent to war without any arms. They don't have any good immunity. They are easily attacked by infections and then they are down. So we are very particular about infection prevention for these babies.
Okay.
And so as much as possible, mothers are taught basic hand washing skill. You can't enter the NICU without washing your hands with soap and water. So that is basic.
Okay.
And then again, you don't touch after changing baby's diapers and touching baby, you have to wash your hands again. Same as because they have nutritional needs, they have specific nutritional needs. Sometimes you might want to use a cup and spoons to feed them if they don't have good suckling reflexes. So we also teach them how to keep these things well so that babies will not get infected, as well as their stuff, the things they use for the babies.
Okay. Okay. Dr. Ampansako, do you have anything to add?
Yes. And they are also taught that they shouldn't let a lot of people come around the baby. You know, when there's a baby in the home, a lot of visitors are coming around to visit and all that. But as Josephine said, these are babies who have very, their immune system is not that mature. So they are prone to getting infection. And the more people are coming around them, handling them, breathing on them, sometimes even coughing on them and all that, it also increases their chance of getting infections. So we also counsel the mothers to limit the number of people who come to see the babies and even handle them. The father, the immediate family members can help. It's not only the mother who can do it. Sometimes the mothers are tired, and so the father or the mother-in-law with the baby's the maternal grandmother can also come and help. So just a few people who are there to offer support. should be around and not so many people. We also teach them to honor their appointments because these babies need follow-up care. There are certain long-term complications that may come up. Their growth needs to be monitored, their development needs to be monitored, and all that. So we teach them to keep the appointments. So when they are told to come, they come, and then we check if everything is okay. And then if there's something that they need to be told, we also tell them. So these are some of the things that we tell the mothers.
Okay. But how long will a premature baby usually stay in the hospital before they are discharged home?
Okay, so that depends on how premature the baby is. Sometimes if you have a baby who is very premature, 28 weeks, 29 weeks, so that's 28 weeks is about 6.5 months to 7 months. So the younger you are, or the more you are likely to stay at the NICU or the baby you need for a long time. And then you also have some who are, 34 weeks and are likely to go home. And there may be also the preterm babies who may come with certain complications, or they may have other conditions. So if you are a preterm baby and then your lungs are not well developed, you are having breathing difficulty, and you may be kept there for a longer time. So, I mean, for as long as you're breathing and you're having challenges with your breathing, you will be kept there. And some of them may stay there for a longer time. If you have feeding problem, so we want the babies to at least be able to feed by cup or by spoon if they are not suckling before we let the mothers go home. So if the baby still has a tube connected to the stomach to be fed, they definitely cannot go home. So they have to stay longer until they are weaned off that tube and they are able to feed at least by cup or spoon on the express breast milk. If they have infections and it's not being treated totally, then they would also stay for a longer period. If they develop jaundice, they will stay for a longer period, So it actually depends. Some may stay there for months, some just a few weeks, and then or days, and then they are discharged. So it actually depends. There's no fixed period. It really depends on the mother, and even sometimes how well depends on the baby, but sometimes how well the mother is able to care for that baby. So we may realize that the baby is doing well, but the mother, so as in the baby is not sick, doesn't have any complications, infections that are treated, is breathing well and all that. But the mother may not be well equipped at handling the baby. So that one you want to keep the mother there and until you're sure that the woman can really care for the baby very well before you let them go. Or at least the mother has a support system. So somebody, an older sister, the mother, or the mother-in-law is around to support. And these people are well equipped with how to handle the baby. Then you can let the baby go home. So it really depends on a lot of factors on how long the baby will stay at the NICU.
Right, right. So I'm enjoying this discussion, but we'll go for a quick commercial break, and when we get back, we'll continue. Please do stay tuned.
Life can be challenging, sometimes hard to find hope even in the midst of difficulties. But even in our darkest moments, there is always a glimmer of light.
The Adventist Church, mission-driven purpose, and Hope Channel brings to you Living with Hope,
A 9-day national Bible lecture series. Keynote speaker, Pastor Kojo Chumesi, health and wellness, Dr. Kennedy Donko, Marriage and Family Life, Pastor Samson Chumesi, and Empowerment Development, Dr. Kofi Chumesi.
Coming to you live from the Penkwas Adventist Church, Sunyane, living with hope. 9 days of transformation and empowerment, starting on the 1st to 9th December 23, 6:30 p.m. each night, live in all Seventh-day Adventist churches and also on Hope Channel and its social media handles. Share the word, tell a colleague, invite a friend. Living with hope.
Ye kaye nshiro ne abubo din kronkron ne ahwede onyame ayama ye mfie wa ha yi mu memenda kwa for I wo Mountain View Ghana Conference also for penny Pastor Ike Kunedu Edano ene asafo ne din di kwamai ezi asafo enya mfinhia wa ha hooray eni gisemi munti finhia wa ha yi mu no mu da nyame ase no mabo hu dwata na kese ato safre ni pebino memenda kwa hwefo Ghana fo ene ni pebino wa mono ne achichiri benche nyina se momre na ye nyina ye nkamomie ni afigide enhye erwadidi ene wonyam
Taye titrunti ye ni dwumadie ni say ye pese ye si nursing school edeboa sechere kwamai enti bekan ho na dwumadie ni wie peye
eno nti busumi du mienum ni da etosu mienu
aye 2nd December 2023
fiye mu
awo sechere kwamai SDA school park ne so ehona nhyiamu no eba Pastor Bismarck Nyantachi awo ye host pastor no asaye district pastor sechere kwamai
udwemtene ni awotene dwom aboa ma dwumadie si ne na so ye Kwame Osei Prempe oye CEO Goya Ghana Dr. KK Sapon Kaneno wono na ne penny pa CEO Emma GNPC afei onumanyamfo Simon Osei Mensa wono ya santimante musuafo no so ya to yensa afre no dia wode ne nimonyam kese ebete dwumadi ase ama na koso wano Ghana mampeni na nado danko akufado dwumadi yi okasafo ya to yensa afre na obetene dwuma kasa aboma dwumadi ya koso eye
Pastor Dr. Anobuahin
wono ene ye Northern Ghana Union Conference
waye SDA asafu dwemtreni moma yende awrade ase esanse waye niema bebrebe ede ma SDA asafu ewo sechere kwamai hallelujah
kwamai memenda kwamefo asafu edi mfinhia wa ha hooray
Welcome back to the consulting room. Tonight we're talking all about premature babies. I'm sure you've learnt a lot so far. Dr. Abibio, so in unfortunate cases where during delivery the mother dies, what happens to the premature baby?
Okay, so for us as obstetricians, maternal death is so important to us, and it's always a very unfortunate thing. So on our part, we try as much as possible to look at the mother. The mother is our primary concern, because if you have a baby who comes into this world without a mother, it's always a devastating thing. So in as much as possible, we want to prevent this from happening, but we make sure that we have the relatives on board. Okay. And then anytime we anticipate a preterm birth, like I mentioned earlier, we get the pediatricians involved. And since we would probably be more focused on, the mother probably resuscitating, sending her to the ICU and all that, we would have handed the baby over to the pediatrician to take care of. But definitely social welfare would also have to come, especially if the relatives are not around and if there are financial constraints and all that. But I think the pediatricians would also want to add something from their point of view.
Okay. Dr. Amponsa Kodia, we've handed it over to the pediatricians.
The baby to her. So we need as far as medical care is concerned. So the things I mentioned, giving them warm, giving them medicine if necessary. And then we definitely involve the social welfare. So sometimes the baby may have, other relatives who would be able to take care of the baby. The social welfare comes in, they ensure that yes, this can be done, and then they even follow them up for a while, to make sure that yes, everything is going on well. They are taking good care of the baby. In the event where there's really nobody in the family to take care of the baby, then the social welfare would have to take this baby in to one of their centers or their homes and then care for the baby. So in terms of feeding, because there's no breast milk, then the baby definitely has to be given um, artificial feeds, so formula feeds, and that is what will sustain the child. And we also encourage that it is done for 6 months before they switch to the other feeds, porridge, and then other feeds. So yes, if the mother that we give all the medical care that we have to give, and then we let the social welfare also come in, and then get other relatives on board if they can help, or the social welfare will take the baby in, where there is no one in the family who would want to take the child. Yeah.
Right, right. But how soon should they get their vaccinations? Can they start immediately after they are born?
Yes. So as soon as they are stable, so they are out of breathing difficulties, we've cleared all their infections, they are not getting low temperatures, their sugar is also not going down. That's also one thing that happens. Their blood sugar can go down and all. So once all those things are cleared and the baby is well, definitely they can get their vaccines. And the first vaccines are actually given on the shoulder and then through the mouth. So if they can swallow, yes, they can be given the vaccine, the polio vaccine, and then the other one is given under the skin. So definitely they will get some place to put the vaccine. The challenge we have with the mothers when it comes to vaccine is the one they take at 6 weeks, 10 weeks. The one they inject into the thigh. Oftentimes they are so scared that the babies are so small. The injection, if only you have muzzle, the baby has muzzle that they can put the vaccine in, or the injection in, they can receive their vaccine. Don't forget that once the baby is born, they are exposed. They are breathing the same air we breathe. People are handling them and all that. So they can't get those infections that the vaccines are supposed to protect them from if they are not given the vaccine. So mothers should not be worried. Once they are stable, they can go ahead and get their vaccines.
Right, right. Okay. So Josephine, we are almost out of time, but you are a NICU nurse. If you can share any experience with us, something that stood out for you, maybe a premature baby that came to the NICU and made it out alive. If you can share any outstanding experience with us. Hi, Josephine. Okay. I don't know if Dr. Amponsa Kodia has any such experience to share with us. Hi, Dr. Amponsa Kodia. Hi, Dr. Amponsa Kodia. Can you hear us? Okay, unfortunately, I think they can't hear us. So I think I'll take Dr. Bebio's final words to our viewers.
Well, I think that prematurity is definitely something that we should talk more about, because we are having a lot of from the obstetrician's point of view, a lot of lifestyle changes and a lot of certain medical conditions that are causing women to deliver before the time they are meant to deliver. And it's important that we raise awareness so that we know how to handle such babies. We clear whatever misconceptions that are associated with premature babies. And I think one thing that Josephine said that really stood out for me is about the mother-baby unit. And I was trained in Confanoche, where Dr. Gloria is. And it's a mother-baby unit. The mothers are near their babies. They can always go to them at any time. Unfortunately, we don't have such at Kolebu. And I've had a close friend who, you know, had preterm babies, and that was one of her challenges, you know, going up and down. The stress alone will cause you not to even produce the breast milk that you are supposed to feed your babies with. So I think that we have to raise more awareness for stakeholders to actually realize the difficulties that mothers with preterm babies go through and try and make life a little easier for them, especially in our government institutions. Make the care a bit better, make it a bit bearable, because the psychological, you know, effects alone of having a baby that's preterm is, you know, it's overwhelming. And in as much as possible on our part, we would also encourage women to, you know, go for preconception counseling, because everything starts during the antenatal period, the prenatal period. If you have certain diseases, certain medical conditions, they have to be tackled before you take seed, in order to prevent you from having a difficult pregnancy that's going to end up with you delivering before your time. And then we encourage women to also go for antenatal care to receive, you know, the right information, so that if you're having a problem with, say, your placenta, or the babies are going to have a problem, you can prepare adequately towards, you know, delivering a preterm baby. And as always, we also want to encourage women to, you know, take the care of themselves seriously, nutrition-wise, because like I said, it's more common in women who are have a low BMI. So women who are not well nourished, they are prone to infections, they are prone to, you know, giving birth before the time. If they have any STIs they need to be screened for, we can pick all that up before, you know, they go into preterm labor, and anticipate and then prepare accordingly, so that even if they have to be delivered before the time, it will be in the right environment where they can receive the right care that they need.
Right. Thank you so much. Dr. Amponsah-Cody, are you there? Okay. So we'll take your closing remarks.
Yes, thank you very much for this opportunity. In fact, when it comes to preterm babies and then the awareness, we cannot get tired of talking about it. And what I would plead with the general public is to support these women. You know, if you see a mother with a baby in the KMC position, the one that Josephine demonstrated, don't look at them in a funny way. And a lot of them get stigmatized. I mean, everybody puts their baby at their back. Why is yours in your front? And they don't understand. So it makes the mothers not shy away from doing that, especially when they are outside. So we need to understand these things. And then also, if you have a family member who has had a preterm baby, you need to support. And some grandmothers of these babies are really the brain or the power behind the lives of these children, you know, and there are stories like that. They actually actively take part in taking care of the baby. You know, the mothers can get so tired sometimes, so they come on board and then they help. Grandfathers, aunties, you know, you all come on board and help. And this is also a time for people to visit the NICUs in their areas, their towns where they live, and also offer support in cash, in kind. You ask them, maybe it's just a pulse oximeter, what they need to measure the oxygen level in their babies that the facility needs. You can provide that for them. You know, come to a Ejisu Government Hospital where I am and bring your support, what in kind, whatever you can provide. But visit the nearby MBU or NICU and then see how you can also help. You see, you never know which of your relatives or your loved ones would benefit from that item that you are donating to that facility. So let's all try and be philanthropists this month and then help our NICUs and our baby units. Thank you.
Thank you too. Josephine.
Okay, I would also want to add that to tell especially preterm mothers that they are strong women. They should continue doing the little things they are doing for their babies. That the little things they are doing for the babies are making very big impacts on the babies' lives. The small things, the feeding, the regular breastfeeding, the skin to skin they are doing. I know that it would pay off. They should be encouraged and know that the very little things they are doing would be of great impact for their babies. And again, to the state and to benevolent societies, that there are lots of things we could do to help some of these people. I mean, like the one I said concerning the mother and baby unit. People can do it by themselves. Even an individual can decide to build such a facility for some of these hospitals. They should come to our aid and help us so that we can all help Mother Ghana.
Thank you so much. I have nothing else to add to these comments. Thank you so much to my guests, Dr. Vibio, Josephine, and Dr. Mponsakudia. Thank you for sharing your knowledge with us tonight. And I hope the viewers have enjoyed this discussion and learned a lot from it as well. Thank you all so much for joining us tonight, and we hope to see you again. Have a good night.